All right, Daniel, how's it going?
Going okay. How are you doing today?
Doing well. Doing well. I appreciate you coming on to the Healthcare Growth Cycle podcast. This is awesome to have you.
Yeah, no, I'm excited to be here. So
Good
looking
stuff. Yeah,
forward to
and
it.
just for the listeners as well, Daniel represents Ohio proud. So, the goal is to try to get as many Ohio listeners on as possible. And this one is definitely satisfying that goal. So this is really exciting.
Yeah, no, I'm excited. Love what you've been doing with the podcast. So yeah, happy to be here. Happy to
Awesome.
represent Ohio.
And then one sec, if you want to just, I think it'd be helpful for the listeners to start out by just giving a quick intro and kind of explain some of your background into healthcare.
Yeah, no, happy to it. So I kind of have a very non-traditional background into where I started, where I got to today. Actually had no healthcare background when I graduated from undergrad. I was an art student. Ended up doing a couple of things in the general startup space, everything from end of life to contemporary art to co-working. This was like pre-WeWork, which will kind of date the time period. But eventually got a role at an advertising agency that was in primarily the B2B space, doing a lot of sales into financial services, healthcare, and manufacturing. Got recruited away after a few years there to really launched the digital arm of a different agency where I was put in charge of all of their healthcare clients. That was everything from senior living facilities, continuing care retirement facilities, and medical devices. About the same time, I met some engineers who were really interested in um, starting something. They were, like me, at an agency, this time as engineers, building medical devices. And so I had been selling medical devices on behalf of others. They'd been making them. So we decided, hey, let's do this together. Can't be that hard. Turns out it's a lot harder than we thought. So what we expected to take about 18 months and $1 million took about $45 million in 7 years. But ended up founding a company called Lazurite, creating the world's first fully wireless, minimally invasive surgical camera for like rigid scope endoscopies, and that's what kicked it off. Since then, I kind of stepped back from my operational role there, where I was a co-founder and chief operating officer, went into the SaaS space, so focused in that case on patient management, or not patient management, medication management and patient support for rare and orphan disease, and then was recruited from there to do telemedicine. I ran a large telemedicine clinic as the head of business operations. And then about a year ago, I stepped back from my full-time role. I'd been doing some consulting on the side and working with a number of other startups, as kind of like side things. And I decided to fully, focus on the specialty advisory practice, really helping firms in the healthcare and health IT and telemedicine space essentially bridge the valley of death between launch and scale. So validate, build, scale
Yeah.
healthcare startups.
Wow. So could you walk us through a little bit more about what it's like to be a chief operating officer of a healthcare company? What are all of the functions? Because when I think of operations, I think mainly of revenue operations. But there's so much more that goes into it, right? Like there's like a customer success component, I'd imagine. I don't know, but I would just like to hear a little bit more about that.
Yeah, it's a really great question, and it's a difficult question. Actually, in my last role where I was leading business operations, one of my co-leaders, the head of our clinical practice, once came up to me and said, Daniel, I literally have no idea what you do. And so I had to create a PowerPoint presentation, like what does it mean to lead operations? Because it can mean a lot of different things. And in fact, at each company, it is it is different. It's a highly heterogeneous term. So in early stage startups, whether they're healthcare or not, operations pretty much is the catch-all for everything that isn't product um, or sales.
Okay.
Basically, it's like what keeps the business running. So that's health. That's like human resources that can have some customer support, customer success. Typically, it's anything with legal, accounting, finance, regulatory, um, facilities. Like, I was the guy who fixed the printer kind of thing. Um, but that's really more of an artifact of how small the teams are. As these things expand, you can kind of push things off into other areas. But I would say the core of operations, and especially within the healthcare space, is around the having the it's what makes the clinic or the company itself kind of really run.
Sure.
So the operations in this instance would be something that's like you're looking over um, how the facility is operating, what your to some extent like what the underlying vendors that you're working with. You'll probably be involved with the tech stack to some extent. You're not making decisions about development or choosing necessarily what's going into or out of a tech stack, but it is an important part of you understanding like what is the system on which the business runs. The other thing that's really important to recognize is that there's a business operations side and a clinical operations side. And clinical operations is operations, but it's like a subset of that. And that's when you're thinking about what are the protocols that you're using? What are your triage pathways for the clinicians? What is the utilization rate of the clinicians? Kind of you can think of all of that. And then if you put that on the business side, there's a lot of analogs, like what's your revenue operations look like? What's your cost of customer acquisition that can fall under marketing, but there's also um, this data component. I
Okay.
really like this. Yeah, I like to say that that's kind of I don't know if that's helpful, but
Yeah, I think it is. Well, I just noticed your background was a lot of marketing focus, at least starting out. Again, I'm
mhm,
just grabbing this from LinkedIn. So from what I can
yeah,
see, but that overlap with operations has always been a blurry line for me, like chief marketing officer versus chief operating officer. But the interesting piece that you bring up here is that there's a whole clinician component, clinician operations, from a healthcare specific side. And just to call that out is really important, even from my perspective, whether I end up working with some chief operating officers a little bit more closely, the metrics that they might be interested in is not only business, but clinical as well. That's a huge takeaway.
yeah, and that's the other thing is operations as it is so varied. Um, it also kind of is where you come from. There are a lot of people. The COO role typically is the second in command. There's the CEO who's the visionary, who kind of like sets the tone and leads the business, and then the COO who kind of runs the business. So, in many ways this being a COO is more about like where you are in the hierarchy than like what your specific skill set is. Because there's a lot of people who go from being a chief marketing officer into the COO role,
Okay,
from being a CFO into the COO role. So,
sure.
my background was really from a marketing commercialization go to market side into it. But I have friends who took the clinical side or the strategy side or the finance side. The thing that I do like to say about operations um, is that you're kind of the bad guy. Your entire role is to essentially find inefficiencies and improve them in the business. Like you're looking for things that are breaking or are broken that you can then fix, which means you have to have tough skin, because if you're just going around and making sure everyone's like, oh, hey, you're doing a good job, then you're really not a particularly effective operator. The joke that I always say that was told to me once by a mentor of mine is that the being in operations is a lose-lose job, because if everything's going well, everyone says, "Why are we paying you?" Everything's going well. Clearly, we don't need anyone to like help with the operations. And then if everything's going poorly, they go, Why are we paying you? Everything is going poorly. Clearly, we don't need any help in the operations. And if you know anything about business, obviously those are completely incorrect assumptions.
Yeah.
But it is one of the reasons why, if you look at like Fortune 500 companies, the highest rate of turnover every year is in the chief operating officer role.
Whoa. Okay.
Yeah, you
Interesting.
just it's
What's
easy
the
to get burnt
political?
out.
Is there a political dynamic there? Like just ego? People don't when things are going well, they don't feel like they need you, and then you said when things are going poorly, they feel like they don't need you either. What?
It's some of that. Like back to the CEO COO
Sure.
dynamic, the CEO only gets fired if they do something that's like beyond the pale. They get arrested or they do something that's like so far beyond, you have to get rid of them. They're like a martyr. If things are just going wrong in the business, the CEO, you can just take to the COO and be like, ah, they've messed it up. And so that's part of it is you're the punching
Steak.
bag.
Yeah.
But the other thing is
Wow.
exactly what like where we started this conversation. No one knows what operations does. Like when I left a previous role, um, the first thing that they did was they dissolved my team. They said, "Well, we don't. Daniel's no longer leading operations. We'll just get rid of Daniel's team, and just give the bits and pieces to everything else. Like, oh, hey, you were working on revenue ops. You're just gonna report to like the head of marketing now. Like,
Sure.
oh, hey, you were working on regulatory. That's kind of related to clinical. We'll put you under clinical. Oh, hey, you were doing like government affairs and governance stuff. We'll put you under like PR. Um, and so it's really easy for people to just not understand how everything fits together. And when people don't understand how things fit together, um, they assume it's not relevant or not important. This is the clearest example of this is in marketing. Um, how many people? So you're a technical guy if someone comes to you and you explain your job, they typically will be like, "Oh wow, that's so intense. Like, I could never do like that development or that math. It's like so technical." At the same time, how many times have you heard someone say like, "Oh, I work in marketing or I work in social media," and everyone goes, "Oh yeah, I could do that. Like that's
Oh,
easy."
yeah. Yeah, and actually, just to add on that quick, Daniel, I used to work in corporate marketing, and, I even sold cars one summer, when I
Mm-hmm.
was, just out of my freshman year of college, and you should have seen the look on some of my parents' friends' faces, or, like, not to
Mm-hmm.
call anyone out, but, like, "Oh, he's a car salesman. What is he doing? He's going to college. Shouldn't he be, like, in an
Mm-hmm.
internship or, like, something?" But I've always found that it always comes back to sales and marketing as the most important skills. And I don't know if I'm taking any of your thunder away, but I'm just really passionate on this as well. So I'm happy we're getting into this.
No, you're exactly right. And that's exactly where I was going with the operations. Is people look at that and I've worked with founders who have told me, "Daniel, I would hire you, but this is a quote. I would hire you, but the only reason I would do that is that I'm too lazy to do what you do."
Exactly.
And I said, "What do you mean?" And they said, "Well, you just like answer emails and look at spreadsheets. Like I can do that. Like I can get like ChatGPT or something." Um, and to which point I responded to this individual, like, I've been paid a lot of money for over a decade to do this, and you've never worked like in this field before. I think
Exactly.
there's a bit more to that, but people have a hard time seeing that because they can't necessarily understand. There isn't there isn't something they can grasp on that says, "Oh, this requires a degree," or "This requires something that like I don't know."
Wow. Yeah, it's just so interesting. From a consulting angle, I almost like look up to marketing agencies or sales consultants who are like able to I feel like pitching a service or a product to help boost your sales is the same goal with data analytics, but data analytics outside of a corporate setting is that hard to explain, like you just said, makes it, in my opinion, even harder to sell to like an external potential new prospect, client, what have you. So this is like a really fascinating like inverse that we're getting at, where like when you're next to people that are performing other job functions, they might look at a sales or marketing or operations in your case and just be like, "Oh, like, I could do that." Like, it's just, it's just a lot of grunt work, which isn't true at all. But yeah.
Yeah, no, absolutely. Completely agree.
Um, so what are some of the biggest challenges from a growth standpoint for healthcare organizations? Like, what are some bottlenecks just being in operations and being on the ground floor with these things? What have you seen that limits healthcare companies' growth?
So it's a really interesting question. It's it's one that is very, how shall I put this? It's very unique to the specific organization. For an example, the telemedicine company that I used to run business operations for, one of their challenges was the their the way that they were getting it was essentially, it was a revenue, no, is it they were it was how they were acquiring revenue. So it was a telemedicine company that had started primarily, if not exclusively, as a cash pay business, and they were shifting to um, payer revenue, so insurance, commercial insurance. And the challenge that they ran into was that they fully underestimated the nuance of onboarding payers, getting their clinicians credentialed, and then matching those um, patients the to the correct clinician, so
Yeah.
then they could bill on it. So in that case, like, the company was very successful. It was, in terms of, the patients loved it, the staff was great, the mission made a lot of sense, but it was really a nuts and bolts question of saying, like, we've launched in state X. Now we have a ton of insurance providers. We have a ton of insurance plans we're credentialed with, and we have a ton of patients with insurance. But if you don't connect the dots correctly, like, this patient has Blue Cross, and we've connected them with a provider that has Anthem, you now can't bill because those two things are not aligned. And so you've just lost that revenue, especially if you've already switched that patient from cash pay to revenue to payer. So that's a huge problem that I see a lot, and it's kind of like this logistical one. Uh, the other problem, and this is one that I talk about a lot, and so that one is really kind of a big problem for telemedicine companies looking to scale. And so that was one of the things that um, my consulting practice really focused on was, you're entering new markets, you're adding a new service line. How are you connecting the dots? How are you thinking through these things? 'Cause it's much easier to build a plan and then build to a plan than just to do everything live and try to, hook up the pipes as you go.
Hmm.
But the other thing that I would say is really really important when thinking about scale, and you sent a couple of questions over for me, and this is actually part of one of those questions. So what made me think about it is that it's what I call the throw bodies at it problem. This has been the approach for hospitals, for pharmaceutical companies, for payers. This is how they've dealt with, technology or problems for decades. Is that, hey, we have an issue, we're gonna just have someone sit down and deal with that issue. The best example I have of this is, in pharmaceuticals and in patient support programs. um, Typically, what a patient support program is for your listeners, is a bit of inside baseball, but there's two types of pharmacy. There's retail and specialty. Specialty is basically very expensive, and most patients can't afford it. These are drugs that cost 30, 50 grand a month. And so to get around that, the pharmaceutical company knows that it's reimbursable by insurance. The insurer will pay them 25 grand. But that means the patient's on the hook for 25 grand. And the they they know the pharmaceutical company knows the patient doesn't have 25 grand, but and so what they do is they create these patient support programs and they say like, hey, patient, we're going to give you 25 grand that as a coupon, and then it'll reduce the cost of your drug by 25 grand. And then they bill the insurance and get 25 grand back. So it the 25 grand for the patient just disappears. It's like a net zero,
Okay.
minus 25 plus 25. But this works from a business model because the insurance provider is essentially subsidized, is like paying for the drug at a lower price. It's things like this that are why drug prices have gone through the roof. I could go on an entire rant about what PBMs are and how this entire system works, but it's especially pharmaceuticals.
Sure.
However, within that, you need to do a lot of coordination because you're moving this money around. And so the patient will need to talk to a patient support program. The patient support program is run by the pharmaceutical company, and then they work with the manufacturer or with the pharmacy. And so typically, because pharmacy to this day is still predominantly run on fax, is like a patient will communicate, will talk to a patient support program, um, and they'll literally just call them. And then if it's during business hours, the person will call them back. And then that person will typically have to call the doctor's office, and then that doctor's office may have to call an insurer. It's a phone tree. Um, if you have 1,000 people making phone calls, the approach is, well, then we'll just hire 1,000 people to sit at the phones. Um, and that has been the system forever. And so you start to see as these drugs get more expensive, as these processes get more expensive, people just throw more bodies at the problem rather than relying on technology and say like, hey, can we automate this? Can we put in some phone trees? Things like that. They're building band-aids upon band-aids, and they're like, oh, if we had rebuilt this from the beginning, we could just use like some sort of machine learning, some sort of like touchstone phone tree, but we're not building it from the beginning. We're building it
Hmm.
from like 20 years of incremental changes. And so it's a big problem in pharmaceutical companies. And then I literally ran revenue operations for a company that was designed to solve this. But you see it the same way in hospitals. When you talk to hospitals about revenue cycle management, how do they do it? They just have a bunch of people sitting around that call insurance companies and say, hey, I'm going to do an appeal, or they have a bunch of people typing out appeal letters. You see it on the insurance side. How do insurance providers deal with appeals? They have a bunch of people listening to those phone calls. And so that is a huge problem with scale
Yeah.
because as we're seeing things get more efficient on one end, which is driving margins down, it is not happening on the other end. You know, the marginal change of having one person who's making 40 to $90,000 a year, there or not, um, is a significant number on one level, but there isn't anything to replace them because it's not like, oh, I can add an AI agent to replace this one person. You'd be adding that thing to replace an entire department, and there's
Yeah.
too much risk there and too much institutional loss. So that's a huge cliff.
This is huge. And revenue cycle management, I love talking about this. So when you say if efficiency goes up, but it drives margin down, if I heard that correctly,
Mhm.
is
Yeah.
that because the revenue cycle management essentially can't pay or get paid fast enough so the cash flow can't keep up to that operational efficiency? Am I thinking about that right, or is that off base?
It's partially that, and it's
Okay.
partially just the trend of healthcare is one of the reasons people are driving towards making things more efficient is that they're just making less money. A great example of this was, I think, 2019. So don't quote me on the date,
Sure.
but I think it was 2018 or 2019. I was sitting in a talk at the Cleveland Clinic. Their head of pharmacy said, these specialty pharmaceutical drugs, as I was just talking about, they're getting so much more expensive. Payers are doing all of these crazy things with formularies where You can use Wegovy, but you can't use, this other GLP-1, even though they're functionally the same because we've got to deal with so and so. And it's like a lot of these just deals that are happening. And
Mhm.
so the Cleveland Clinic said, "Hey, you know what? We're going to be efficient. We're going to redo our formulary. We're going to look at all of our pharmacy. We're going to renegotiate contracts." And they spent like 6 to 8 months doing this, and they cut out like $12 million in costs without changing care by just renegotiating it. It was a big win. The end of the year, 4 drugs changed their prices and eradicated everything. The 4 manufacturers were just like, "Oh yeah, this is more expensive now," and it like increased their cost by like $15 million. And so you're seeing people drive towards efficiency, not because they're saying, "Hey, now we can make more money," but in many cases it's like we're not going to survive.
Holy
Rural
cow.
hospitals are driving towards efficiency not because rural hospitals are printing money, it's because rural hospitals are dying.
Wow. Wow. And is it that if operations at a health system get more efficient, that pharmaceutical companies are like, "Well, now we're gonna jack up the cost of these drugs." Is that correct? And
I wish it was that simple,
okay,
because then you could just be like, "Ah, we're gonna not be
just
efficient."
not be a
But uh, it is a problem that's gonna be hard to solve.
That's really interesting.
Not
Man.
like not to I'm not even gonna be political, but I will mention some political things. There are Republicans and there are Democrats in the Senate who both have introduced rules to crack down on these drug pricings. Examples being a company like a Bristol Myers Squibb or something like that will license an asset out of MIT or something, and $100 million in government funding will have gone into that asset at MIT. They'll license it into the drug manufacturer will bring it to market, and then they'll say something like, "Hey, we have to have a really high drug because otherwise we can't afford to to develop these things. They're very
Mhm.
expensive," which is true. The problem is the money that was spent to develop that was spent by the government. It was not
Right.
spent by the company, and so a lot of people in the government are pointing at this and being like, pharmacy benefit managers, these other companies, they're really playing kind of fast and loose in this. Some of it also has to do with the fact that we're in the United States, which is how drugs get paid for. Drugs are not this expensive outside of the rest of the world. It's just in the US. So
True.
there's kind of like a, hey, if you want the development, we can put it here. But I'm not gonna like complain about drug prices forever. To get back to your point about
Sure.
efficiency, um, I think in general there is there's a there's been a lot of changes around healthcare, quote unquote corporate practice of medicine, private equity getting into hospital systems and really, this drive towards efficiency, like let's make these nonprofits more profitable. And I think part of that really is a response to insurance companies reimbursing less.
Okay.
So you need to do more with less drugs, and therefore your input costs being higher. If you're getting paid 10 grand for a patient and 8 grand of that is just going to pay for the drug, then you have $2,000 to pay for everything else. And so within all of that, like operations is incredibly important. There are things that we can do but you also have to kind of get creative. Some of it is pushing back on these pharmaceutical companies. Some of it is getting together with other operators, group purchasing organizations, like seeing how you can leverage those things. But yeah, it's a complicated
Wild.
problem.
Yeah.
And
Thank you
this
for that
is,
breakdown. It's
yeah,
all like a very deep insight for me. Really good exposure. So I know I'm like probably asking like some broader questions, and then it's like, well, it depends, or there's always
yeah.
multiple factors. So thank you for walking us through that, Daniel. Um, on a more business centric growth note again. What and just advising healthcare, health tech startups, in your venture capital, experiences and currently, what you're up to at some of these different VC firms, and advising. What are some attributes that you look for in early stage successful health tech companies? Because I think it'd just be good for the listeners that are listening. It's probably a lot of health tech founders. I know it is, and it's a lot of healthcare executives as well. What are some attributes that you look for promising health tech startups?
It's a really good question, and I think about this a lot. Um, the single most important thing that I look for, that I have looked for, that I've seen is material clinical interest from practicing clinicians. And I'll give you the example that I always give is something called the Da Vinci surgical robot. It came out 10-ish years ago. It was supposed to be the greatest innovation in cardiothoracic surgery. It's a beautiful robot. It's incredible. Engineering feat amazing. Got Wired articles. The company Intuitive Surgical, it's a unicorn, made ton of money. But the purpose of the robot was to help with reduce injury during cardiothoracic, like open heart surgery. And the problem it was solving was, hey, you know what? What's the most common complication in open heart surgery is someone like cuts an artery and then someone immediately kind of bleeds out. It's very dangerous, can cause death almost immediately. So a bunch of very smart people got together and said, okay, well, we'll just make this robot that gives you incredibly precise control. So you no longer have to like worry about sneezing and then like, cutting something, or like maybe you have a tremor or a shake and you'll like cut an artery. They created the robot, cost millions of dollars. Um, then they gave it to some surgeons, and this is a hospital system, and I'm not going to say which one, but like their head of cardiothoracic surgery was using the Da Vinci robot. This was the first Da Vinci that they were using. The hospital just bought like a dozen of them. They had at the time more Da Vincis than Intuitive Surgical had. They went into the surgery, and almost immediately the surgeon nicked an artery, the exact same thing that this thing was designed to prevent, and threw the machine away, basically, and said, I'm never touching that again. Went in, fixed the artery, completed the surgery, and mothballed all these machines. And the problem was that you had a bunch of these really smart scientists reading these injury reports, reading these adverse event reports, and saying, hey, here's the problem. Our solution is control. Like this person coughed, and then they cut this accidentally, so like we need to have this like very minute control. But they never actually talked to anyone or never actually participated in the surgery, because what they failed to understand is that everyone is physiologically unique. And so when you're going in and you're doing this surgery, you're using your hands to feel the difference. Oh, is this muscle? Is this an artery? Is this a vein? And that's really a lot of how you can tell where to cut, where not to cut. And the Da Vinci had no haptic feedback. So basically, they took something and it made the surgery far worse. Um, but if you read the articles, you just heard about these innovations, how beautiful, how amazing it was. Now, the Da Vinci has been a success. Took a couple of years, was never used in cardiothoracic surgery, but it's used in urology,
Sure.
where people are physiologically very similar, and that control is very necessary. And I think they added haptic feedback.
Interesting.
But
Yeah.
um, but that's a great example of what I call a science project, not something that's clinically relevant. And so when I look at companies, what I want to see is I either want to see founders, scientists, whomever embedded in hospitals.
Wow.
Myself and my co-founders, like, yes, one of them was a biomedical engineer, but none of us were clinicians. But what we were is we were in the operating room every day. We were in the hospital. We spent our entire time talking to physicians, not VCs, not engineers. And so we had a fundamental understanding of what was there. We were making decisions based on what people who are actually doing the surgeries wanted. And as a result, it meant that when we had the product, when the product was kind of in development, we already had people who wanted to use it, who were giving us advice. We were getting market acceptance before we'd even built anything.
Oh,
On the same side, you know, I saw something on LinkedIn a week ago, and it was an incredible post. It was by this woman who was a nurse. I think she may be head of a nursing association, and she said, if you don't have a clinician on your founding team of your healthcare company, then you're not a healthcare.
wow.
You're a you're a technology company that is a healthcare product. And I saw this. I've seen this so many times. I was working with this one telemedicine company, and they said, well, hey, we're building this AI agent. It's going to help us with uh, prior approvals, prior auths for our clinicians. So like we stopped getting denials because we don't have the PAs done. And I looked at the guy and I said, why are we building this? We're a clinic. We provide clinical services. And he said, no, I know this is going to be great. We're going to build IP and it's going to make our valuation much higher. And I said, we
Hmm.
can just buy this. Like we can buy something off the shelf. He said, no, we have to develop it internally. And that's a great example of someone who's this is no longer a healthcare company. This is now just a company that has a healthcare product. And in this case, it was going completely backwards. We made our money by providing healthcare services, but we were investing in some technological thing that was at best secondary or tertiary to what we were doing. And so
Sure.
that's where I see that's like my biggest red flag.
Wow.
If you can't draw a direct line between what you're doing and the patients that you're helping, you're not a healthcare company. You may have products that are relevant to healthcare, but that that's gotta be first front and center for me.
Man, yeah, that's a huge point, and it inspires me from a data perspective, whether it's healthcare or manufacturing or roofing even. I mean, I did roofing for a little bit, a year or 2 ago. It always comes back to sitting with the operators that are actually practicing the trade.
Mhm.
And I completely resonate, with this as a data professional, being as close as possible to the actual front lines to be able to understand the inputs that are actually even generating the data on the back end. So, this is a huge insight. I appreciate it. All right. Well, Daniel, we're at about 40 minutes, so that's about time. What I'd like to do is just give you the floor. Where can people find you, connect with you, reach out? We'd love to just kind of plug your social medias or whatever. And yeah, I'll give you the floor.
Absolutely. Well, I really appreciate it. Probably the easiest way to find me is on LinkedIn. My LinkedIn is the Daniel Dudley. So if you just put that in the LinkedIn bar, or you can search for my name. Typically one of the first ones who pop up. I will say I do look very different, so maybe that's like not a good one. Um, for social media, like that's my main go-to. I still technically have a Twitter account or an X account, which is Daniel_Dudley. Don't use it very often, but the best way to connect with me would be through if not through LinkedIn, would be through my website. So that would be Danley, Danley. So the first three letters of my first name and the last three letters of my last name .is. And that's kind of the epicenter of all of the stuff that I'm doing. I have some
Awesome.
other uh, things that I'm working on, which are you'll find if you look me up. My Yatra advisors. I work with something called Grand Rounds Capital. I do a lot of EIR stuff, but Danley is the center of it all.
Awesome. Well, we appreciate you coming on, and this has been a really insightful episode. I love that we got more into the revenue cycle operations side and dove into payers, and I mean that side of it's extremely interesting. Maybe selfishly for me as a data professional on the healthcare operations side of the house. But ladies and gentlemen, this is episode 11 of the Healthcare Growth Cycle podcast, and we will see you on the next episode. Thank you.
Thank you. Bye.